This is the University of Otago.
Welcome to University of Otago, Christchurch. For those who don't know me, I'm Peter Joyce and I'm Dean of this campus. It's my great pleasure this evening to introduce Professor Cynthia Bulik, and I think I know Cindy fairly well because as part of her career, she and her husband Patrick Sullivan worked in Christchurch from 1991 to 1996, and many of her earlier publications and my earlier publications, we were co-authors on many papers. When they got the call to return to America, although I think her husband followed Cindy to Christchurch, Cindy had to follow Patrick back to America because of a job offer that there was no way we could match. But she had a wonderful idea for a treatment study on anorexia nervosa, which was an interesting challenge, and as soon as we got the money, she decided to leave and left us to complete the study here. But it was a great study, and thank you, Cindy, for designing it. So by way of background, Cindy is trained as a clinical psychologist, did her initial training in America, was at the Western Psychiatric Institute in Pittsburgh, where she did postdoc training, and she came to University of Canterbury in 1991. As I said, she and her husband were then recruited back to United States with offers, as I said, that we couldn't match. In recent times, she and husband have been primarily at University of North Carolina, but in addition, in recent years, they also have a joint appointment with the Karolinska Institute in Sweden, so that Cindy and family are spending part of the year in Sweden and part of the year in the United States. She told me over the weekend she'd actually much prefer to spend part of it in Sweden and part of it in New Zealand, but that's not the case at the moment. In North Carolina, she set up a Centre for Excellence in Eating Disorders, and it's a great pleasure tonight to introduce Professor Cynthia Bulik, who is going to talk about eating disorders, replacing myths with realities. Cindy.
Thank you very much for that introduction, Peter, and welcome everyone. And I took note that Peter said that it is not yet a reality that I could spend half of my time in Sweden and half in New Zealand, so you might get an email from me following up on that. I want to welcome you all here tonight, and to the people who will watch this later. My goal tonight is to really hopefully give you some new information to change the way that you think about eating disorders. And I'll start off with some disclosures. I am a consultant for Shire Pharmaceuticals, and I write books for Pearson and for Walker. And these are some of the wonderful groups that have funded some of the research that you're going to hear about tonight. Replacing myths with realities. I think the eating disorders field has suffered perhaps more than any under misconceptions about what cause eating disorders and how to treat them. One of my idols, Gloria Steinem, said the first problem for all of us, men and women, is not to learn, but to unlearn. So part of what I'm hoping to do is giving you some new ideas about how to help other people unlearn, because I view talks like this as sort of really being able to spread out like ripples. If we can all come together with some new thoughts tonight, then you can go out there and you can share those new thoughts with other people, and we can really change the way that people think about eating disorders. Just briefly, I want to make sure we're all on the same page in terms of what these disorders are, and I'm going to talk about three of them primarily. So anorexia nervosa is perhaps the most well-known, the most visible, the most written about eating disorder. Significantly low body weight, an intense fear of gaining weight or becoming fat, and a disturbance in the way in which one's body weight or shape is experienced, undue influence of body weight or shape on self-evaluation, or I like this new piece, this is from the new DSM-5, or persistent lack of recognition of the seriousness of the low body weight. And I think that probably captures it better than all of the ones that we've had in the past in previous diagnostic systems. You have a restricting subtype where people only reduce their caloric intake and increase their physical activity, but you can also have binge eating and purging together with anorexia nervosa. It has the highest mortality rate of any psychiatric disorder. And some of the research that we did here in Christchurch actually showed that. It has now been replicated in several countries around the world. And I think this is really important because when people trivialize eating disorders or say things like anorexia nervosa is just a passing fad, they need to know this. They need to know that it's about 5% per decade of follow-up die from this illness. And the standardized mortality ratio is somewhere between 6 and 10, depending on the study, which means that someone with anorexia nervosa is 6 to 10 times more likely to die than their age-matched peer without the illness. And the suicide rates are astronomical, and they range in different studies from between 10 and 50%. But suicide is a common cause of mortality in anorexia. And it is the third most common illness amongst adolescents. The first myth that we're going to bust is that you can tell by looking at someone that they have an eating disorder. People always think that you have to be thin or emaciated to have an eating disorder. That is not the case. So when you see this red sign, that means it's a myth we're going to bust. Eating disorders come in all shapes and sizes, and in fact, the new diagnostic system actually allows you to get a diagnosis of anorexia nervosa even if your BMI, your body mass index, isn't low. So it's recognizing that you can have all of the features of the illness and not be at very low body weight. And that's really important because in the past, those people have often been denied treatment because they don't fit the stereotypical picture of what anorexia nervosa is. Second disorder is bulimia nervosa. What's a binge? Really hard thing to define. We spend so much time trying to decide if an eating episode is a binge or not. But according to the books, binge eating is eating in a discrete period of time an amount of food that is definitely larger than most people would eat during a similar period of time and under similar circumstances. But the key difference between binge eating and overeating is that sense of loss of control. So once the person starts eating, they feel like they can't put the brakes on and they can't stop the eating episode. That's what differentiates it. In bulimia nervosa, binge eating is coupled with inappropriate compensatory behaviors. That might be self-induced vomiting, it might be excessive exercise, it might be laxative use, but something to undo the effects of the binge. And then there are all these criteria at least once a week for 3 months, but as far as I'm concerned, this is an unhealthy behavior, and if it happens less frequently than that, it's still of concern and is worthy of intervention. And again, self-evaluation is unduly influenced by body shape and weight. And then the third disorder that has often just been put in sort of a wastebasket category now in the new classification system has a real home. So binge eating disorder is a bona fide eating disorder now, and I think we're all going to start seeing more and more of it in the clinic now that it has a home in the diagnostic system. What binge eating disorder is, it is the same as bulimia in terms of binge eating, so eating an unusually large amount of food and feeling out of control, but in the absence of those regular compensatory behaviors. So what that also means is metabolically, people with binge eating disorder are often, but not always, overweight. So there are people in the normal weight range and the underweight range who have binge eating disorder as well. And there are also all these little extras like eating much more rapidly than normal, eating until uncomfortably full, eating when not feeling physically hungry. But some research that we did showed that all of those are actually captured by this criterion, which is marked distress regarding binge eating is present. So people who binge eat feel distressed about the loss of control over their eating. There are also some independent health risks associated with BED. So people thought originally that any of the health risks that we saw with this disorder were just secondary to the fact that most of the people were overweight or obese. But when we controlled for obesity, what we found was that women with BED actually have more insomnia, they tend to smoke more during pregnancy, they also continue to binge eat during pregnancy. So what we've seen in some research that we've done in Norway is that women with binge eating disorder keep binging, and this actually affects the size of the babies when they're born. So they have more large for gestational age babies. And we're following those kids up now to see if that actually means a different weight trajectory for them over time after birth and through childhood. And they have a greater risk of having metabolic syndrome. Men with binge eating disorder, and I think this is really interesting, they have higher anxiety, more smoking and alcohol use, and many more pain syndromes. So we hear neck and back pain, all sorts of muscular pain, and also just greater impairment due to physical and mental health, and also at greater risk for metabolic syndrome. So if anyone tries to tell you that binge eating disorder is somehow less severe than anorexia or bulimia, it's not the case. We're seeing a lot of psychiatric and medical comorbidity associated with binge eating disorder. So here's another myth, and this one I just want to like kick straight out of the stadium. Families are to blame. The number of patients that I have had come to me and parents that I've had come to me and told me that their GP or their physician said that the reason their kid has an eating disorder is because of their parenting, I cannot count how many times that has happened. What it does is it makes people shy away from seeking treatment, and it's my job and all of us health professionals' job to educate physicians and other healthcare providers that this is a myth that is completely and entirely unsubstantiated. And if you look, well, we'll just take it one step further. And it's not just parents, but we got to add moms, because moms always seem to be the ones that take the brunt of the blame for any psychiatric illness. Mothers are not to blame for anorexia nervosa or any eating disorder. Let's look at the history of psychiatry, how we've done this to other disorders. First off, there is no prototypic eating disorder family. They come in all colors, all varieties, so many different types of families eating disorders develop in. We had this first, Bruno Bettelheim talked about the refrigerator mother and autism. For how many years did people think that autism was caused by a cold and distant mother? Now we are perfectly comfortable knowing that autism is a neurodevelopmental disorder. And if anything, parenting is the most important thing in helping these children live successful lives. Same thing, schizophrenia. Frieda Fromm-Reichmann, the schizophrenogenic mother. So what a horrible term. Again, saying that mothers somehow cause this horrible biologically based mental illness. As much as I love some of his writing, I think he was a great writer, I think Minuchin sort of started taking us down the path that somehow families were to blame for anorexia nervosa. He talked about the psychosomatic family. He wrote really interesting work about what happens when you bring the family together during a meal. But he was also looking at a very select population. He had a clinic in Philadelphia where mostly upper middle class people could come to. And frankly, by the time a family comes to me with a child who has anorexia nervosa, the anorexia has affected the family. It's not that the family caused the anorexia, it's that the anorexia disrupted the process of the family. And I think sometimes when we see people late in that process, all people see is that cross-section of a family in distress, and then they make false assumptions about that family being a causal factor. In contrast, families are often our best allies in treatment. And especially when we look at the treatment of children and adolescents with eating disorders, getting those families involved whenever possible and whenever appropriate is really important for long-term success. So here's the fourth myth. The fourth myth is that eating disorders are a choice. Once again, absolutely not. And part of the problem and why people have continue to believe that eating disorders are a choice is because what I call the tyranny of face validity. So we see images like this all the time in the media. We see, all these fashion weeks are going on now. Back in the 60s, we had Twiggy, Calvin Klein continues to use really skinny models. People look at that and they think that there's a correlation between this and what we see in the clinic. What they don't know, and I apologize for the image because it can be triggering, and if you don't want to see it, just close your eyes. But they don't see the difference between a model and what anorexia looks like. Nobody would put a picture like that on the front of a woman's magazine. And frankly, this is not what leads someone to develop anorexia nervosa. There might be a small percentage of people who say, I want to look thin, and then they go on a diet. But that diet is what triggers the anorexia nervosa, not the models. I'm not saying that the media aren't to blame, because they are and we need to regulate them, but what we need to look at is who the people are that are most vulnerable to those messages, that when they engage in the behaviors that those messages suggest that they engage in, pulls them down into the abyss of anorexia nervosa. Lots of kids can go on a diet and never develop an eating disorder, but some people are highly vulnerable to a diet. Eating disorders are illnesses, they are not choices. No one chooses to have an eating disorder. All right, one more myth. Eating disorders are the province of white upper middle class teenage girls. This one is a problem. This one is a big problem because physicians don't see beyond their preconceived notions of who has these illnesses. I've had so many men come into my office and so many middle-aged women more recently saying they've even gone into their doctor's office and said, I think I might have an eating disorder. And the physician will say something like, I don't think you really fit the profile. I don't think that's what's going on. Let's do a whole bunch of tests. And they do tests and tests and tests to look for these occult problems when the person actually came in and said, I think I have anorexia nervosa. And again, what that does is that make people go back into their shell, go back into the shadows, and feel less comfortable talking about the fact that they have an illness. And this is just a slide to remind me that one of the dimensions that eating disorders don't discriminate on is race and ethnicity. So again, there's this myth that this is this white upper middle class phenomenon. We have seen eating disorders across different racial and ethnic groups. So again, we have to keep that on our radar screen to make sure we're always alert and always have eating disorders on the differential. Another group, completely underserved, and I think we very much underestimate the frequency with which they develop eating disorders, is men. And if we ask them the questions, they tell us. So in this survey, 1,800 men in the United States, when we asked them the question, 26% of them said they overate, 20% said they lost control, and that's actually high, because one of the things that we find is that men don't, apologies to all men in the audience, but men don't like to admit to loss of control. So we've actually had to change the way that we ask the question in order to extract the information from men. So I think part of our statistics are wrong because the questions were actually developed for women in ways that women feel comfortable answering. So we actually have to change it around. So men are more likely to say, I stuff myself with food, than they are to say, I feel out of control. So if you ever get a man who says no, ask it a couple different ways to see if you can get that information out. 8% talked about binge eating weekly, 1.5% purging, and 3% used laxatives. These are concerning numbers for a male population. The lesbian, gay, bisexual, transgender, transsexual community, there are a couple things that are going on here that are worth pointing out. First off, the prevalence of eating disorders is somewhat higher in gay men, but not that much higher than in heterosexual men. And there's been this myth that's been around forever that if you're a man and if you have an eating disorder, you must be gay. So a lot of straight men who have eating disorders will go to their physician, or they won't go to their physician because they're afraid that immediately they're going to be tagged as being gay. Not that that's a problem, it's absolutely fine, but it's something that keeps people from seeking treatment. So again, it's another myth we have to get past. And there's no difference in prevalence between the lesbian and straight women in terms of prevalence of eating disorders. So again, keep everyone on your radar screen. Age. This is the latest topic. I'm not sure what's happening in New Zealand, but we have seen a complete shift in the demographic of people who are coming in for treatment for eating disorders. When I started my program in North Carolina in 2003, they wedged us between an adolescent unit and a child unit because we predicted that most of our patients were going to be adolescents and young adults. Within about 2 years, over 50% of our patients were over 35 years old. And now it's well over 60% of our patients who are adult or midlife women. And I'll give you some numbers and then I'll tell you more about who those folks are. So we did an online study called GABI of 1,849 women aged 50 and over. We looked at body image, aging and identity, eating and weight loss, attitudes and behaviors, because no one asked the questions. Everybody just sort of assumed that you grow out of eating disorders. So we actually didn't have a lot of data on what's going on in this population. Lo and behold, numbers are going to look kind of familiar. 8% reported purging in the last 5 years. This is women 50 and above. You just don't think about that, but it's happening. 3.5% binge eating, which is right on par with the younger population, 7.5% diet pills, 7% excessive exercise, 2.5% water pills, 2% laxatives, 1% vomiting, and this number kind of blew my mind. 41% of these women talked about body checking daily. And body checking is an eating disordered behavior where people like feel their fat or see how like wide their thighs are or their wrists, just measuring to see if their size is changing. So this is a really common behavior in women over 50. And clearly, you don't just outgrow disordered eating. But I think most importantly are the feelings part of this survey. 62% claimed that their weight or shape negatively impacted their life. That's more than half of the women. 36% reported spending at least half of their time in the last 5 years dieting. 79% said that weight or shape affected their self-perception, and 64% said that they thought about weight or shape daily. This is so much woman brain time being spent thinking about these issues. I mean, if you really do the math, it's no wonder that we're kind of like not doing everything that we could be doing, because we're spending a lot of time thinking about this stuff well into our 50s, 60s. Some of these women were in their 70s and 80s. We had women said that they're worried about what they're going to look like in terms of their weight and shape when they die, because they want to fit into certain dresses when they're laid out. And they were serious. So it doesn't just stop with age, but nobody ever asks older women what they're thinking about. Why is this happening now? Well, as you'll hear in a minute, genes play a big role in risk for eating disorders. Your genes don't change over time, but the triggers in the environment that might activate those genes do change. I think what we're seeing increased pressures in society not to age. It is just not cool to like be getting wrinkled and gray and things like that anymore. And every single industry is selling you products to try to get you to change your behavior. People are afraid of losing their jobs because they're aging out of the job market. So there are a lot of behaviors that older women are engaging in to attain this young ideal that might be triggers for an underlying genetic predisposition to eating disorders. The expectations of aging have shifted, and these horrible phrases like 70 is the new 50. No, I mean, in an over 50-year-old body, I know 50 is not the new 30. I feel really different as a 50-year-old woman than I did as a 30-year-old woman. But we've got these environmental triggers. Genes load the gun, but environment pulls the trigger. And we're just getting more environmental triggers that are aimed at people over 50. And it's not just women, guys are next. My daughter Natalie, who's here somewhere, wrote a great blog post about the latest absession. Men are told to be completely obsessed with their abs. You cannot open a magazine or turn on television without someone flashing their 6-pack or their 8-pack or their 12-pack, whatever it is. We have little boys who are, playing, soccer or rugby, whatever, at really young ages, starting to judge their own bodies because they don't have this muscle definition. And these are just little memes and mind worms that industries are getting into our heads, saying that we need to reach some ideal that is physically impossible for the vast majority of us to reach. So no one is safe from these pressures. Some of the triggers that we're seeing in midlife, lots of loss and transitions. So we see infidelity, empty nest when all the kids leave, or a troubled nest if some of your kids are having difficulty, or what we call bounce back children. You just think they're out of the house, and then all of a sudden they come back again. And that can be another trigger. Unemployment and financial concerns, illness or surgery, totally under-researched, perimenopause. We know that puberty is a risk factor for the development of eating disorders in women. In fact, we know that all of a sudden the genetic factors that lead to eating disorders come online after puberty. But we submitted a grant to the National Institute of Health a while back to look at what happens during the perimenopausal transition. And NIH came back and said, well, we know puberty is an issue, but menopause, nah, that's not going to have anything to do with eating disorders. Yet we're seeing this rise in disordered eating behavior all around the perimenopausal transition. So it makes sense that these are sort of like hormonal bookends that lead to disordered eating on both sides. But people don't want to believe it again because it goes outside of their normal preconception of what happens with eating disorders. Death of a loved one, retirement, and trauma or reactivation of traumas are also triggers. And part of it is like, I say there's no niche for grandma anymore. There used to be just wonderful roles that grandmothers could play. This is a nice Italian grandma making a pizza. This is actually my great-grandmother, so my dad's mom's mom. She made lace, and she cooked, and she baked, and she had a great garden, and I sat on her lap, and she read me books, and she just had this wonderful role, and she was I think, comfortable in it. And it felt as if she had a place in society and a place in the family. But these are the latest things I saw. So this woman, won some bodybuilding competition, and the headline was, "Want to look like this at 72?" And this poor woman is somewhere probably out in Seattle. She's sort of like a hipster grandma, and it's like, and this is the new image of what we're supposed to look like when we're in our 70s. Our bodies don't do that naturally, and it's almost as if you're doing something wrong if you allow yourself to age. The next myth that I'd like to bust is that eating disorders are benign. And again, this goes back, and I'm going to say it one more time because I hear it so often, is people who don't come into treatment early because they think this might just be a passing fad. She'll grow out of it, he'll grow out of it. And all kids go through that. Same thing for adults. Eating disorders are not benign. Eating disorders affect every bodily system. So just a couple pictures: cardiovascular system, gastrointestinal system, musculoskeletal system, and dental system, and more. And this is something that is especially problematic in our middle-aged patients and beyond. Since eating disorders basically wreak havoc on your body, if you're already over that sort of like hump of maturity where these systems are starting to be on the aged side of the hill, and then you insult them with an eating disorder, we're actually seeing more medical problems in our adult patients than we see in some of our child patients. So it's really critical that people in midlife get themselves into treatment and get physicians that understand and will make sure that all these systems are being watched carefully and monitored for problems. And then this is just some data that we have from Sweden, again showing that eating disorders are not benign. It shows suicide rates across the different eating disorders. So if you look over here, this is the suicide rate in the population, so people without eating disorders. It's a little under 2%. And then down here you see the suicide rate for anorexia nervosa of the restricting type, the binge purging type, people who have had both anorexia and bulimia at some point in their life, binge eating disorder and purging disorder, which is when people purge in the absence of binge eating. And as you can see, these are massively elevated suicide statistics. And suicide actually, Sweden actually has one of the lower suicide rates for eating disorders. So numbers like this are comparable across the world in eating disorders. And then another myth, that society alone is to blame. And now we're going to do a little bit of genetics education coming up as well. So I'm going to tell you what I take as a starting point. So for the past maybe 20 years now, I've been doing research on familiality. So do eating disorders run in families, and are they heritable? Is this something that you can inherit? And what we found is eating disorders absolutely run in families. Sporadic cases can happen. So we see people who have no eating disorders in their family. But what we might see in their family is some depression, some anxiety disorders, maybe some substance abuse. But more often than not, eating disorders run in families. They are heritable. Things can run in families for two reasons. They can run in families because they're transmitted genetically, and they can run in families because you model some behavior. Your dad buys a Ford, you buy a Ford. It's sort of like, you see it, you like it, you grow up with it, you do the same thing. It has nothing to do with your genes. But other things like your hair color, your eye color, your height, they do run in families because of genes. What we have learned from twin studies in multiple countries is that genes play a substantial role in the liability to eating disorders. We don't know which genes they are yet, and I'll show you the search for the genes in a moment. But we also know that environment is important, and the twin studies have shown that. But what's probably going to come out in the end, it's not an either-or issue. Both genes and environment are going to be operative in increasing someone's risk for an eating disorders. So gene-environment interactions, correlations, and epigenetic factors are most likely operative. So here's the part where I'm going to teach you a little bit about genetics if you're not a geneticist. We have entered what is known as the genome-wide association study era. And this study by one of my, well, actually it's my husband and one of his postdocs, surprise. To our knowledge, this is the first time in the history of psychiatry where there is a clear path to increasing our fundamental understanding of these disorders. And this is a slide that is basically Cindy Bulik on a rainy Saturday morning having way too much time on her hands. There are 22,000 dots on that screen, and those dots represent all of the genes in the human genome. These ones up here, it's probably a little bit bigger than this now, are the ones that we know something about. The rest of these are still like mystery genes. We don't know what they do yet. Even more importantly, for a long time, we thought that all these little spaces in between the dots, in between the genes, didn't do much. But now we know that even the spaces in between genes are functional and things happen. Some of it isn't functional, but some of it is very active and can influence the way the genes are expressed. So it's a massive amount of work. For decades, we did what was called candidate gene studies. And what we did, because we thought we were somehow omniscient and could figure these things out, is we said, ha, that gene is associated with anorexia nervosa. And then we would go out, we'd get 100 people with anorexia, we would get 100 people without anorexia nervosa, and we would compare that gene. And often the first study that would be done would actually find a difference and say, ha, that gene is involved with anorexia nervosa. But then 10 more groups would do the same study, and they wouldn't get that result. We had a parade of non-replications. And lo and behold, all of those studies for all of those years yielded no genes that influence risk for anorexia nervosa. So what the GWAS era is, that instead of like thinking that somehow we have this godlike knowledge and can pick out a gene, we now do a technique that basically canvasses the entire genome. We don't have to make guesses about the biology. We don't have to guess what gene it is. We can just take large numbers of people and compare them across the entire human genome. And that's what a genome-wide association study does. What comes out the other end is something called a Manhattan plot. Pretty simple to read. The reason it's called a Manhattan plot is because these are supposed to look like skyscrapers on the Manhattan skyline. And what you're looking at in the bottom is all of the human chromosomes. And what you're looking about over here is the significance level. In this magic red line is anything above that is significant. And what that means is that that gene is associated with whatever disorder you're looking at. In cases, so people with the disorder versus controls, people without the disorder. This is a lovely Manhattan plot. These people actually have skyscrapers, and it looks wonderful. Doesn't always turn out that way, and I'll explain why. So I was watching all of the other psychiatric disorders way ahead of us, and there were no GWASs being done of anorexia nervosa. So literally, I was in a hotel room in Germany. It was Christmas time. The snow was coming down, and I started calling all my friends. I started calling all my friends all around the world and saying, do you have any DNA in your freezer from people who have anorexia nervosa? And I found people in 15 different countries who did have freezers filled with samples from people with anorexia nervosa. And we put together the genetic consortium for anorexia nervosa and got funds from the Wellcome Trust in order to do a genome-wide association study on all of those samples. The first one that was done, also from a consortium that we were involved with, this is the Manhattan plot. You know how to read it now. You see the red line, and you can see that there are no dots that go above the red line. It was a wash. We did not find any signals. We thought it was a big sample size. We had 1,000 cases and 3,700 controls. No signal. Do we get upset? We do another one. But this is the GCAN one that I was talking about. We have 3,000 cases, 14,000 archived controls. Once again, there's that magic red line. No dots go above it. Was I depressed yet? It's really hard to get me depressed. What we know now that we didn't know then is that size is critical when it comes to genome-wide association studies. This is an old slide now. It needs to be updated. But these big circles, alcoholism, nicotine use, type 2 diabetes, now much bigger, schizophrenia, bipolar, all of the disorders where we have had success in genome-wide association studies have large sample sizes. There was no way we were going to find significant hits on a GWAS in this itty-bitty little anorexia nervosa sample. And that's really what we're doing here now, is trying to expand this sample, get more cases so that we can have the same kind of success as other psychiatric disorders. And this is like, schizophrenia is the poster child for psychiatric genomics. And this is what gives me hope about the work that I'm doing in eating disorders and that we're all now doing in eating disorders. This is what schizophrenia looked like. Their first study had 3,000 cases, and their Manhattan plot looked just like ours. There wasn't a single building on that skyline. But they didn't give up. They kept forging forward. And then they had 9,000 cases, and they had 5 significant hits. Then they had 14,000 cases, and they had 22 significant hits, and then 31,078, and now they have 34,000 cases and have identified 108 genes that contribute to schizophrenia risk. And what they can do now is they can prioritize those, they can drill down, they can look at the biology, they can figure out what the biological pathways are, and start to drill in to understand what the biology of schizophrenia is. And where that can lead down the path is then to look at new interventions, perhaps new pharmacologic interventions that can really target the disorder based on a known biology, not a hypothesized biology. And this is where we are. Eating disorders is behind. So schizophrenia looks great. Major depression actually is up to 100,000 now. So these other disorders are just way far ahead. Anorexia is down here. We're pushing it up, but we've got a long way to go to catch up with the other disorders. So unless we continue to believe, and hopefully after all this myth busting we won't, that anorexia nervosa is purely a sociocultural illness, there is absolutely no reason why gene discovery in anorexia should not follow the same pattern as schizophrenia. So efforts are underway to increase sample size. The Klarman Family Foundation has funded the Anorexia Nervosa Genetics Initiative, which was just United States, Australia, Sweden, and Denmark. And they funded us to collect 13,000 cases and controls. Angie is now, as of tonight, growing, and we're adding New Zealand to that list, thanks to Jenny Jordan and Martin Kennedy, who have jumped on board. And we're going to do what we can to give everyone in New Zealand the opportunity to participate in this study. We have a parallel study going on in the UK called Charlotte's Helix. Charlotte Bevan was an amazing woman who died from breast cancer a little over a year now. And her dying wish was to develop a foundation to bring genetic research in anorexia nervosa to the UK. So we started Charlotte's Helix in her name, and Jerome Breen came on board, who's never done research in eating disorders before, but now he's a huge champion to move Charlotte's Helix forward in the UK. And Canada's Helix is about to be born as well. So we've challenged the field to reach 25,000 anorexia cases by 2016, and we further challenged the field to reach 100,000 eating disordered participants by 2018 by expanding out to include bulimia and binge eating disorder. So what I want to be really careful of is that a myth, we don't want people to think that genes are destiny. So I think one of the dangers of genetic research is people say, oh, I've got the gene for anorexia, I'm destined to get it, or my mom had anorexia, so I'm going to get it too. That is not the case. As you can see with schizophrenia, it's not just one gene. These are complex disorders, and they're caused by multiple genes of small effect and environmental factors, and they come together. And environment, we have to look at it, because environment plays a role. An environment can play both a positive and a negative role in the development of eating disorders. On the negative side, environment can increase risk. Things that we know about are sports with an appearance or weight focus, dieting. Everybody always gets on the modeling community, and I don't know if any of you saw, France had a bill out that was going to ban underweight models, and it looked like it was going to go through, but I just read today that it didn't go through, and I think there are good reasons why it didn't go through. They said it actually discriminates against people who are naturally at low weight. And there are people who are just naturally thin who don't have eating disorders, and they weren't going to let anybody under a BMI of 18 or 19 be on the catwalk or something like that. Israel has passed such a law, and I haven't heard yet how that's going. An obsession with looks, and very under-researched, but we have a paper that's going to come out on this, just the role of teasing and bullying in the development of all the eating disorders. And not just being bullied, but also being a bully, which sort of surprised me, that both of those things are associated with increased risk. But environment can also serve a buffering effect. It can't necessarily stop the onset of an eating disorder, but it can be a buffer. And so some of the things we look at is modeling healthy eating, really helping people separate their body esteem from their self-esteem. Because I think when those two things are conflated, then you get to the point where you really can look at weight loss as a strong reinforcer. Role models for body respect, family involvement, supportive peers who value who you are, not how you look, but also letting parents know that you can't control everything. I know so many families that were perfect buffering environments and the kids still develop eating disorders, or the moms or the dads still develop eating disorders. And so it's not like you can control the environment so well that an eating disorder won't emerge. So this next series of slides is a way that I just try to help people understand what the different quadrants of risk are and protection are in the development of eating disorders. I'll take a brief detour and explain that one of the things that I think that happens in anorexia nervosa is that people who are prone to the illness have a paradoxical response to food deprivation. So most of us, when we get hungry, feel terrible. We get irritable, we get scratchy, people don't want to be around us, we might get headachy, and we get shaky and we start looking for food. It is not a feeling that we in any way look for or try to create. If anything, we try to avoid it. People who are at risk for anorexia nervosa often feel that way at baseline. And what they find, sometimes when they go on their first diet or sometimes when they're ill and they're not able to eat, is they find that food deprivation actually calms that underlying dysphoric and uncomfortable biology. So it actually is anxiolytic. It decreases their anxiety. Totally different response, biological response than the rest of us have. And it's not until we refeed them and put them in treatment programs and make them gain weight that that anxiety starts coming back again. My job, our job, is to figure out what's going on biologically that makes their bodies respond to food deprivation differently than the rest of the world does. And then in terms of treatment, helping to find other ways to calm that biology that has nothing to do with starvation. We have to compete with how effective starvation is at calming that biology. And that's what our treatments need to focus. And when I talk that way to parents and to patients, they're like, I understand. It's not just about eating. It's fighting an uphill battle against your biology. And that's what we try to get parents to understand, why it's so hard. So back to my quadrants. So this is a very colorful picture of human chromosomes. And these are some traits that we think are related to eating disorders that we all know are genetically influenced. So perfectionism, harm avoidance, appetite regulation, how easy it is for you to vomit, your baseline anxiety, obsessionality, your activity level, your obesity risk, and binge eating. In twin studies, every single one of these traits has been shown to be influenced by genetic factors. That doesn't mean that there are genes that code for proteins that lead to perfectionism, but it does mean that they're heritable and that genes play a role on some level. These are genetic risk factors. There are also genetic protective factors. So, we get genes from both sides of our family, from our moms and from our dads. We get risk genes, but we also get protective genes. So two things that we think might play a role in protecting against eating disorders: constitutional thinness. You never have to go on that first diet because you're naturally thin, and self-esteem. And so the second quadrant are genetic protective factors. The third quadrant are environmental risk factors. So I have a couple lightning bolts here. I've included teasing and dieting as two of the things that can sort of like activate the genetic soup. Environmental factors that can lead to the expression of some of those underlying genetic predispositions. And then the fourth quadrant is environmental protective factors. And here I include like a sports coach who focuses more on strength and what your body can do rather than how much you weigh or like be thin to win or something like that. I include family meals because lots of research showing that family meals are pretty protective, and breastfeeding because breastfeeding seems to be good for all sorts of outcomes. An individual's risk is influenced by the magnitude of contribution of all four of these quadrants. It's just what cards you've got dealt, what environments you've been exposed to, what the genetic shuffle was when you got genes from your mom and from your dad, and what the balance across these are. We can't do anything about the genetic quadrants at this point. All we can deal with is the environmental quadrants. But what we want to be able to do eventually is to use the genes to understand who's at greatest risk and to use the genes to understand the biological pathways more, so that we can actually develop interventions that work with anorexia, bulimia, and binge eating disorder. Myth number 9, eating disorders are for life. Not the case. So they're treatable. Recovery can and does occur at any age. Nutritional rehabilitation and weight restoration are essential for anorexia, but are only the first step in treatment. Cognitive behavioral therapy works well for bulimia and binge eating disorder, but we have not done a good enough job at figuring out how we treat those people for whom cognitive behavioral therapy doesn't work. We really need to answer that question still. No medications have been shown to be effective in the treatment of anorexia, in part because we don't understand the biology yet. Medication can play a role in the treatment of bulimia and binge eating disorder, and individuals with eating disorders can thrive after recovery. And people with very severe and chronic eating disorders, we can help them to live more fulfilling lives. And I think that's something that we have to spend more attention looking at. Cure doesn't happen for everyone, but for some people we can make their life and their quality of life better. What can we do now? We can do early detection. We can never again say that an eating disorder is a passing fad, but get people in for treatment early. We can intervene early. We can work on prevention, although I'm not terribly convinced that any of our prevention efforts actually work yet. We can be really careful in our obesity prevention programs. The last thing that any of us want to see is an obesity prevention program that gives us more business in the eating disorders field. We have to be so careful not to cause another problem by virtue of trying to prevent or treat one. We can screen in primary care. It's really simple. Every time you go to your doctor's office, the first thing they do is they throw you on a scale, but nobody ever asks you how you feel about your weight. Really simple question. Many physicians are afraid to ask questions about eating disorders because they don't know what to do if someone says yes. So we need to give them the tools and the places to refer people if in fact they do screen positive. We need to screen moms with histories of eating disorders. So many of them come in for their prenatal care and don't talk about having an eating disorder because they're worried about being judged. And we need to, because tonight what we're doing, we need to destigmatize eating disorders. I look forward to the day when someone's as comfortable saying I have a history of anorexia as saying I have a history of asthma. It's not the case yet, but there's no reason why it shouldn't be. I don't make that sort of brain-body distinction. Now, the realities. Eating disorders do not discriminate. Just recapping some of the things that we talked about. You can't tell by someone's size whether they have an eating disorder. Families do not cause eating disorders. They can be our best allies in treatment. Both genetic and environmental factors influence eating disorders. Eating disorders are serious, biologically influenced mental illnesses, not choices or passing fads, and complete recovery is possible. So now I have an invitation. My invitation first is to follow me on Twitter. I tweet a lot about eating disorders, and both research and things that are in the news. Read our blog, both from UNC and the Karolinska Institute. We write often about research on eating disorders. And visit my website, cynthiabulik.com. And an invitation to New Zealand. And that is to give every person in the country who wants to, who has suffered from anorexia nervosa at any point in time in their life, to participate in the global effort to find the cause and ultimately to find the cure. I would like to thank Nikki and Emma, who I didn't know was going to be here tonight, and Edance for supporting Angie. One of the things that we found around the world, and actually it's so heartwarming to see partnerships between families, patients, advocacy groups, researchers, clinicians, to come together in a global research effort like this. It's never happened to me before in my life, and I'm just sometimes overwhelmed by emotion with how this is happening all over the world, because this is the only way we can get that kind of sample size so that we can catch up to schizophrenia and have the same kind of results that we're seeing in the other psychiatric disorders. My goal, and I have a lot of people in my sort of social network world who are in the eating disorders advocacy and family community, is to never wake up again to see another Facebook post or another tweet that says that someone has died from anorexia nervosa. I want there to be no more loss of life from this illness. It's a big task, but I don't see why, through some of this research and this partnership, we can't get there. So I encourage you all to visit www.angie.nz. Encourage anyone you know to take a look and see if they want to participate and to join us in this effort. And I think that's all for this part of the talk. Thank you very much.